Right. Very good morning to all of you from Colombo for the day 4 of DHIS2 Analytics Tools Academy. So today, of course, we are moving on to a different dimension in our course that we are going for next 2 weeks time. Because today we are going on to some different topics, not the typical DHIS2 analytics, the DHIS2 tools. So we'll be introducing you to a supplementary tool that we have in the DHIS2. And before moving on to that part, of course, we'll be also introducing you to some concepts of data quality. So even though we have a separate DHIS2 and academy, it's a level 2 academy on data quality, we are hoping to introduce you to the concepts of data quality so that it might inspire you to even join our level 2 DHIS2 Data Quality Academy, which will go into much depths of data quality concepts. But in addition, they have some basic data quality concepts that is required even when you are doing DHIS2 data analysis. So we'll be trying to introduce you to the concepts initially, and then we will move on to a separate session which might consume the bulk of the day. About 75% of the time allotted for the day will be on DHIS2 WHO Data Quality Tool. Right, so the sessions will be mostly done by me and Varun today. So I'll be starting off with the introduction to data quality review, which might go to somewhere around half an hour to 1 hour. And then followed by that, Varun will be doing the session for the entire day. One good news for you is that we won't have any graded assignments today. And of course, I'm glad to see that all of you have submitted, all the groups have submitted the yesterday's graded assignment by now. But that does not mean that we won't have any exercises today, because as time permits, we might try to take one ungraded exercise that you might do in groups. Right, so let me check how many are here as of now. We have 33 participants, but unfortunately we won't be able to wait any longer because we have a lot of content to cover during the session today. All right, so we have seen the feedback. Of course, few items that came up in the feedback. One was that to limit the time for 3 hours. Unfortunately, that I don't think will be possible, because during these 4 hours, we are not entirely consuming the 4 hours of lecture sessions, because it's like at least 60% will be the lectures, and remaining 40% is usually the time allotted for the exercise and other discussions. So if we try to reduce it further, we may have to increase the number of days that we are conducting the academy, which I think will not be feasible for most of you based on your other commitments. So unfortunately, that will not be possible. And another good news is that most of you have requested that for us not to have the final exercise on the 5th Saturday. So we have, of course, opted for the majority's decision, and based on that, we will have to continue the final day. That is the day that we are going to have the exam. That will be conducted on 7th Monday. So as most of you have requested, it will be rescheduled. And then also there were a few other requests about assignments, and for example, for the assignments, not to submit screenshot, but to have the customization done in the instance itself. This also is something that we will not be able to at least change during this course of this academy, because this requires some, we'll have to revisit the exercises and the workflows associated with grading, which we cannot and unfortunately do once an academy has started. So we might consider that for the upcoming academies, of course. Right. So I guess we can move on to the presentation now. Let me just share my screen. Right. So in this initial presentation, what we hope to conduct is we are going to introduce you to the WHO Data Quality Tool towards the latter part of this presentation. But before that, we will discuss about what we mean by data quality review. because data quality review is a concept that goes hand in hand with all these analytic tools that we are using in the DHIS2 Analytics Tools Academy. So these tools we use for a couple of purposes. One is to, of course, provide some kind of visualization and outputs of the collected data, which is our primary objective. In addition, the other main objective would be like by analyzing data, we are trying to assess, we are of course, by analyzing data, we are trying to take decisions, right? And we are also deciding on how to plan our health system and our next step for the upcoming years. So for us to take these decisions, we have to be sure that the data based on which we are taking decisions are of very good quality. So to ensure that, we have to take few steps so that the data that we have collected are kind of, we apply some tools and we refine them, that the data that is collected in the system are very reliable for us to make these decisions. So to do that, there are some steps that are associated. Of course, this could be achieved by using the tools in DHIS2, but in addition, there are some measures that countries have been taking traditionally in their day-to-day practice. So we will review and revisit few steps that countries are usually taking to ensure the quality of data is ensured by the usual methods that they are adopting. Just let me adjust a bit my screen. Okay, fine. Right. So the data quality review methods. Now, let me ask a few questions from you all. What are the steps traditionally implemented by the health facilities to ensure that the collected data is of good quality? What do you think are the measures? You can unmute yourself and speak up. So let us talk at different level, maybe at facility level, maybe at district level, or else at country level. What are the steps that they are taking? Anyone? So you collect data, but what we want is to ensure that the collected data is of good quality. What do you do for that?
Data validation rules. Data validation.
Yes, yeah. So exactly, one answer would be data validation rules. Any other answers?
Completeness
of
of
the data.
completeness of the data set and timeline of timelines of the data achieved.
Yeah, so the completeness and timeliness, yes. Anything else?
Data.
Sorry?
Data validation.
Data validation, yeah, of course. You can, of course, ensure the data, validation. So far we have received few answers. Validation rules.
Yeah, comparison with previous available data like survey data and statistics.
Yeah, exactly. Right. So we have already received a few answers, which are all of which are correct. But like, let us just review these things in a systematic way, right? Okay. So how would you do this? Like, now there were answers like, you can compare with the data that is already there with the surveys, and you can, of course, check the completeness and timeliness. So how do you actually do this? What are the methods which are available? Where do you do this? So one available method is like, which have been traditionally used by all countries. Even in, the country I am currently based in, Sri Lanka, we have our own methods. But this is similar to many other countries. Even before the era of these digital systems, these have been there. So one is, we have something called data verification surveys. Okay. So in these data verification surveys, we can perform few steps, which of course can happen at facility level. So this data verification surveys typically means that there will be health staff at national level or district level who would be performing some verification surveys by in fact visiting the health facilities, right? So once they visit health facilities, there are few steps that they are doing, okay? But like, now this, of course, you may understand. So I will just take one example from Sri Lankan context. Now, especially, I mean, this is not just unique to Sri Lanka. For all the countries, this is there. But in Sri Lankan context, we are referring to them as review meetings, right? So yeah, these are verification surveys, but in fact, what they do is kind of review meetings. So what happens is staff from national level, okay, or else from district level, they visit facilities, the health facilities, or else maybe a center in one of the districts. And then by visiting them, they are conducting few activities, right? What are these activities? So one is that what they will do is they will check the manual data entry registers which are there in health facilities, right? So they would visit now in this era. What we would do is we have a HMIS or a health information system. So we have the data submitted by the health facilities to that health information system. So what we're actually trying to do is to ensure that the submitted data is of good quality. So how do we do that by visiting facilities is that we may compare the values entered in the facility register, the forms and the paper documents that they have in the facilities. We will compare whether there is any discrepancy between the documents and registered kept inside the facilities with the data that is submitted to the information system. This is one. Okay. And in addition, what we will do is we will also make sure, okay, now for these facilities to submit this kind of data, there needs to be some basic infrastructure that has to be in place, right? So they may check, okay, they have entered data, but do they have adequate trained staff to enter data, right? If they have not entered, if they do not have trained staff to enter data, then obviously the data that is entered is kind of I mean the cooked up data, right? Or else the data which is not of good quality, because there is high chance that if there is unskilled staff who's entering data, that they might make so many errors, right? So that is one of them. And also whether they have the guidelines and maybe instruction manuals in the health facilities assisting the staff to enter data, right? If they don't have it, then we can very well assume that okay, now the staff is just entering data without proper guidance, right? So they will check, the staff who is performing this particular review will check that whether they have these guidelines and adequate staff and reporting forms which are available as basic infrastructure for them to proceed with data entry, right? In addition, they will also check, all right, fine, that okay, now these people have been collecting data and entering data that they are doing. But the thing is, now, is there any evidence of them actually using this data? So what would be the evidence for them to see that they're actually using this data? What would they require? Now, my question is, I'm asking from you all. Now, this team who visits the health facilities to ensure that these health facilities, of course, well equipped to ensure data quality. We are thinking that if they are ensuring data quality, one requirement is that there should be some evidence of this, the staff in these health facilities are actually using the data. So what would be the evidence this team is looking for when they are visiting the health facilities as evidence of using data? What do you think? What would be the type of evidence for that? Anybody?
Their registers, clinic
They
registers,
are
and
registers, okay. Yeah, so registers, if they are maintaining, it's an evidence that they are collecting data. If we just move one step further, how to
to,
check whether they are actually using
to check
the data?
whether they are analyzing the data and taking any decisions based upon it.
Yeah, yes, exactly. That's the answer. But how would you, like, now what are they looking for down this team? Okay, that's exactly what we want to know, like whether they're analyzing and using data. But what would they, specifically look for this one? All right, let's just make it a bit easy, at least for the Sri Lankan participants, because it's same for other countries as well. Okay, now just imagine you visit a health facility, right? And if they are using data, what would be the evidence? In their offices, they would be having some things, some
Graphs,
material.
some graphs and charts showing the
Ex-
information.
Exactly. Where would they place it? Would I mean these graphs and charts will be in a one file or folder, or they would actually
It
display it in a different
it
way?
it
On the
should be
wall.
on a notice board, on a notice board or somewhere
Right?
everyone
Because
can see.
like if I'm satisfied and if I'm sure that this data is correct, I wouldn't just put this data. I mean, like I wouldn't place these graphs and charts in a folder just so that it can only be referred by me, right? If I'm sure about my data, I would just have them displayed so that whoever who visits a facility will be able to see, right? So I would have them ideally on notice boards or walls. I mean, I will just paste them on walls or notice boards, all these charts, spot maps and stuff like that, right? So if there is such evidence when you visit a health facility, that itself means actually that these people are not just collecting data, but they are in fact using them, right? At least trying to use them. Okay, that evidence we are actually looking for. Okay, right, fine. So these are the steps that we are ensuring, right? We would be like checking, as I mentioned, the facility register, right? And then whether there's enough staff and guidelines, data forms available, and of course, whether there's evidence of data use. But the problem, of course, is now when you are performing these kind of visits, right? You are visiting a facility, right? It's not usually just one person. There'll be like a couple of health staff, maybe some district or national level directors, managers, right? Now this is very time consuming, right? It is not only time consuming, it is resource consuming because it's very expensive, right? You have to arrange transport, arrange accommodation, arrange meals, per diems, right? There are so many arrangements that needs to happen. So this is a very expensive endeavor. And in addition, the thing is what? Like, I mean, how many facilities that you can visit in the country in a given context? Not many, right? So if that is the case, then what you are forced to do is what? What would you do? Like if you can't visit the entire list of health facilities in your country, what would you do? What would you do? Say you have 1,500 health facilities, which obviously you can't visit. So what would you do?
We randomly select a few facilities
Exactly.
and
So you would randomly try to select a few facilities, or you would take a sample of facilities, right? Then of course, I mean, like even in research and everything, if you try to do sampling, then there is always a bias, right? Some kind of bias is there, and whatever judgment, whatever report we are going to produce after doing this facility survey is or facility, yeah, you would call it facility survey, is going to be judgmental because like we have not included all the facilities, right? There is this sampling bias. So this, of course, due to all these main issues that I mentioned, is having that, I mean, few drawbacks in this verification surveys, which we are traditionally performing. Okay. What would be a better approach to this as opposed to performing these surveys, the physical surveys by visiting facilities? I mentioned about this on the very first day. In fact, that's the entire focus of this academy, so that you would be able to do this step that I'm mentioning, which would be, what would be that? As opposed to days where we have to physically visit facilities. If you can remember what I mentioned when I was doing that demonstration on the day one, what would you call that process? Right, the answer is data desk review. Okay, so what we do in a data desk review is we are seated at national or district level in front of a laptop, okay, which runs DHIS2. So if all facilities are entering data, DHIS2 has sufficient tools in it so that without actually visiting the facilities, I'm not saying we can actually 100% fulfill all the activities that we are performing by a physical visit, but to our satisfaction, we'll be able to do a fair amount of job just by sitting in front of your laptop at national level. You can, in fact, as if you can remember, I mentioned how you look at dashboards. You start from there, and how you drill down, right? And how you identify problems, and how you communicate the problems to the staff, right? And how you get their feedback, right? and how you set up next step. Okay, I have seen this deficit, please do this and get back to me, right? And how these notifications are communicated to the end users as messages or as emails, right? If you can remember. So this entire task you can perform just by sitting in front of a desk at national level. So this is called data desk review. So the advantages are you don't need any travel, right? And it is very practical to perform on a routine context. You can just go on doing it because you are just there at the office and you save all the time wasted for travel. Okay. And also this is an island wide, oh sorry, it's a national exercise, national level exercise, and it's not just a sample. All right. And of course the DHIS2 actually permits drilling down. So you can start from national level or maybe at district level. And you can just drill down further all the way up to the facilities and identify the exact facilities which are causing issues. Okay. And in addition, in DHIS2, as we explained yesterday, we have this validation rules in place where we try to ensure and we are ensuring that the data will be of good quality just at the point of data entry. That's the purpose of having the DHIS2 data validation rules. Of course, you can do analysis, data validation analysis also later, but this is what we are trying to achieve. Okay. Fine. Now this data quality review is an ongoing process, right? Because you just can't just do just one-off data quality review. It's an ongoing thing which should be happening periodically, right? So you may conduct it at monthly level, annual, or maybe in a longer periodicity based on your requirement. So what I'm trying to highlight is, I mean, all these frequencies, monthly, annual, right? It should not be happening at all levels. But say, for example, at facilities, district, provinces, they would prefer to have data quality reviews conducted in periodicities which are scientifically justified. So at which level would you recommend to conduct monthly review? Now, you know that in DHIS2 we have several
Facility level.
organization unit level. Yeah. So at level where you would recommend to have monthly review conducted.
Facility level.
Sorry, I heard an answer. Somebody
Facility level.
that you conduct a monthly review. Facility level is the answer, and where else? Maybe I mean yes, facility level plus maybe at one more level you would conduct monthly review. Even for MCH data, now if I take an example from Sri Lanka, the Family Health Bureau, right? Of course, the facility level, the medical officers of health, they have to conduct this monthly data quality review. In addition, uh, at the next level also, they are kind of conducting a little bit of quality review before approving it. What is that level? What is the level in
District level.
yeah, district or in Sri Lankan context, RDHS, Regional Director of Health Service. So basically in global context, it's a level, and then at district level, right? You may conduct a monthly review. So that, I mean, district level, of course, it may be a bit of a cumbersome procedure if you don't have adequate trained staff at district level because you have to go through, you have to go through the data that is coming from facilities all the way up to the district. So this may be a bit of a task, but yeah, you may conduct this monthly review at facility and district level. What about annual review? Now I'm mentioning about annual data quality review. Where would you conduct this annual review? At which level? Of
National
course,
level.
yeah,
National
level you have to conduct an annual data quality review. So when should this ideally be happening? So basically, like you must be having annual reviews, right? Annual information review. So actually this data quality review should precede that annual review because like data quality should be ensured for us to have this annual review, right? So ideally it should be happening at national level, but no harm based on your country context, you can have it at lower levels as well. But that is up to the country, but at least at annual level, at national level, this annual review should take place, right? And then we also have this periodic reviews. This may be like in longer periods, maybe like every 3 to 5 years, right? This should happen as in-depth review mainly for the long-term planning, right? So if this periodic review that we are conducting will affect the strategic planning of your health system, right? So you need to have an in-depth review, which should happen in longer periodicity as well. Okay, so hope everything is clear up to this point, right? Okay, so to facilitate countries doing this activity, the WHO has defined some dimensions that the countries should be using when conducting these data quality reviews, right? So these dimensions have main four areas that they are concerned about, right? So let me mention these areas. The first one is, of course, the completeness and timeliness of data. That is number one. Okay, so this basically are four areas that we'll be considering when we are performing this data quality review, right? Is that clear? Okay, and there may be so many other criteria that you are using, but we are sticking into the WHO data quality review criteria. So the four criteria includes, the first one is completeness and timeliness of data. The second one is internal consistency of reported data. Okay. The third one is external consistency. The fourth one is consistency of population estimates. So what do we mean by, I mean, I will be, so during the next 20 minutes or so, I will be just going through each of these dimensions. So just to briefly introduce what these four dimensions are, the first one is completeness and timeliness. Okay. So the completeness and timeliness, what is it? It's of course, you all are familiar. It's how complete is the submitted data and how timely they have been submitted, right? Because for us to take some action, the entire data set that we are collecting should be completed, right? That should be completed at data set level as well as at organization unit level. If some data is missing, you can't take a proper decision, right? That is one. And it should be timely, right? If I mean, like, if the data is not timely, we are actually reviewing. Why we collect data is to get a snapshot idea about what is happening in our health system, right? Let it be, I mean, if I'm a HIV manager, by getting data, now why are we collecting data? We are collecting data because, I mean, we are not God, right? If we are God, we don't need data, right? We can just see, okay, now, okay, supposing I am some kind of a God, right? Then, of course, I mean, I don't need data. I can just, I mean, I just have to wish, right? I need to see the situation of MCH in Sri Lanka, right? Able to get an overview of the entire MCH situation of Sri Lanka as of now. I don't know what it will be like because I'm not a god, and so I have no experience. But I'm just assuming, right? Then I have this particular visualization. But because we are not so privileged, that's why we are collecting data, right? So data is kind of give us a reflection to the situation. So what happens if this data is not being submitted timely, right? Okay, I wish that I want to see the situation of MCH as of now in Sri Lanka. Of course, this is not possible. At least what is possible would be in the last month in Sri Lanka. But if the data that I am actually getting is not of last month, if is of 3 or 4 months back, then what happens? I mean, I can't get a timely reflection of what is happening. So I can't actually take an action, right? So basically, this is about data for action. For public health action, we need data. And if the data is not timely, we can't take a proper action. So that is why this dimension of completeness and timeliness becomes very important. And the second thing is about the internal consistency of submitted data. So here we are just checking whether the routine data, right, agree with themselves, right? Whether there is any plausible agreement with different data, right? So basically it's something like there are some data which should be similar. It's not the same data item, but it should be similar. But if they are, I mean, ideally, scientifically, they should be similar. But if what we are getting is not similar, then it's obvious that there is some problem with the data quality in one of the data items that we are looking at. Right? We will explain what those are. And the third one is the external consistency of data. So here we are checking whether the routine data that we are collecting match well with the findings from other sources, such as the health service. Right? Right. Now we have one flow of information that is coming from health, routine health data that we are collecting from our information system, and we have another flow that is coming from surveys that we are conducting periodically, right? Ideally, I mean, if we are collecting more or less same data in different frequencies into using these different sources, they should be somewhat similar, right? But if they are not so, then we have some data quality problem. Is that clear? Then, of course, one very important thing is about the consistency of population estimates, right? So here we are more concerned about, about indicators and population, the denominators, because like when we are comparing country statistics, right? Say for example, I want to review country status, some MCH status of different countries in South Asia region. What would I do? I would not ask ANC1 like how many people, how many mothers attended for the antenatal clinics, right? So likewise, I would not be asking raw data which are data element, but here I would be concentrating much on indicators, okay? Because indicators, of course, has a denominator, as Dr. Priyanka mentioned to you when he was doing the customization part of it, right? This denominator is usually some population denominator, right? So because of that, the denominator is a major factor, because ultimately at some level you are just looking only at the indicators, not at the data. Because of that, because the indicators are the only one which is going out of the country, it is very important that you have to maintain updated population statistics which will be acting as denominators, right? Otherwise, you will not have a proper consistency of the data that is going out of the country as the indicators, right? So the number 4 is the consistency of population estimates. So in next few minutes, we will just briefly move on to each of them, which of course will lay the foundation for the WHO data quality tool, which Varun will be starting after me. Okay, fine. Hope everything is clear up to this point. Yeah. Any major questions? I'm just explaining some concepts. So, I mean, if you just ask me why only these 4, I don't have an answer, right? It can be many others, but these 4 are the ones agreed by WHO, right? And so it is accepted globally by most stakeholders. That's all. Right. So first, let's look at the completeness and timeliness of data. Right. So if you can see this slide here, right? What is this slide? This slide is from, of course, DHIS2. And from which analytic tool of DHIS2 is this slide from? You have all done completion. Of course, it's from pivot table. Fine. Right. So what do we see here? We are seeing some data set matrix, right? So you are seeing on to your left, you are seeing what? You are seeing here. Here what you are seeing is these statistics are from data sets, and you are looking at data set matrix, right? And there are so many matrices which are mentioned, like reporting rates on time, actual reports, so on and so on, right? So what we are trying to highlight is a concept called completeness. But even though we mentioned that it is about completeness, there are 2 different dimensions to it. One is completeness, the other one is, of course, timeliness. So what is completeness? Completeness, as you all are aware, is the number of reports submitted divided by the number of reports expected from our DHIS2 instance, right? So that's about completeness. What about timeliness? Timeliness is the number of reports submitted by the deadline divided by the number of reports expected, right? So here we define that this data should be submitted on a particular date, and that's how we are determining whether these reports have been submitted on that date or it has been a late submission, right? So if it is late, that means that's not timely. So not only the completeness, even timeliness matters, right? Okay. So in DHIS2, this is a fairly straightforward process, right? For us to check the completeness and timeliness. So what are the tools available in DHIS2 to check the completeness and timeliness? A question. What are the available tools for this? Anyone?
The reporting rates.
Reporting rates from where? Reporting rate, we can 2 applications in DHIS2.
Reporting rate summary.
Yeah, so reporting rate summary is in which tool in DHIS2?
Reports app.
reports. It's on, yes, exactly. It's in reports app. So reports is one app. And the easy, I mean, so there were two answers. So you mentioned the difficult one. The easier one would be, of course,
The
what you're
pivot,
seeing on the slide.
pivot
Pivot
table.
table, exactly. Yes, so you can get this statistics from pivot table as well as from reports module. So is there a difference, however, from what you are seeing in pivot table and reports app? If so, what is it? What's the difference? This may be a bit of an advanced question if you don't know how DHIS2 works.
We can change the layout, and there are a lot of options in pivot table compared to reporting one.
Yes. So that's one answer exactly. So that means to elaborate on what Dr. Deepal was mentioning. So basically, when we are looking, I mean, when we are trying to get this output from pivot table, we can use many more dimensions, right? Even for example, if it is a facility, we can check the type of facility when we are using the pivot table, right? Whereas if you are just using the reports application, reporting rates, you just can see the different levels. That's all. But you can't actually go into other dimensions. Yes, exactly. And what would be the other one? If you are in a hurry, what would be the other difference? If you are in a hurry to check the analytic, the reporting
Reporting
rates.
rates is very
Give a
quickly.
clue.
We can get reports very quickly from the report app compared to pivot table.
You are correct. Exactly. And what would be the reason? Exactly. That's the answer. But why is that?
Reporting app, it's a predefined format. It is already developed format, format
Predefined format.
types.
And,
But pivot table, we have to think what we want, and it's taking.
all right. Any other answers from anyone? What's the difference between pivot table and reporting reports app when you are pulling these completeness statistics? Yeah, the answer is you all know that all these these analytic tools apps, they are depending on the analytics of DHIS2, right? So when you are depending on analytics, what happens is you all must be aware that at the super user level, you are setting up some periodicity, some frequency to run analytics engine in DHIS2, right? So once this analytic engine runs, only the analysis will be available to the analytic tools. So these analytic tools include maps, pivot table, data visualizer, right? So all these are pulling the data not directly from the captured data. Okay, this is for you to understand some basics of how DHIS2 actually works. This may be a bit advanced, so I'm not going into too much detail on this analytics engine and how it is run and all these things. But the thing is, basically, now whatever you are seeing in the pivot table is not directly pulled from the data that is captured in the data entry app. If you know that much, that's just fine. So what happens in DHIS2 is that, so usually we set it to run at every, maybe around midnight when users are not, many users are there logged into the system. At that time, we are doing a process in DHIS2 called analysis, running the analytics engine. So once you run it, what happens is, all the data that has been entered will be processed, and there'll be some outputs which are generated. Okay, that's how it happens when you run the analytics engine. And basically, whatever data that you are seeing in the pivot table and visualize are pulled from that and not from the data that is directly entered. Whereas in the reports app, it's different. In the reports app, what happens is they basically pulls data from the direct entered data and tries to display. Right. So if you want to, like, say for example, see the reporting rate. If you want to conduct a review, maybe this afternoon, also count in the data submitted in the morning, completed in the morning today. So then ideally you should be using the reporting rates, not the pivot table, because it will only run and show you the updated completeness and timeliness maybe midnight. Okay, hope you get that idea. Yeah, okay, right. So the next one is internal consistency of reported data. So what do we mean by the internal consistency? It's basically routine data that are internal consistence are the data that are consistent with each other. So basically, we are checking the plausibility or apparent accuracy of the data which is submitted. Okay, right. So there are few things which are there that we have to consider about. So this include to determine whether the data are plausible. So, I mean, basically like whether they are accurate with each other, right? So there are so many criteria that we can use to determine whether the, the data that is submitted are plausible. So few of these matrices that we are using are mentioned here. You can see. So one is to check whether there are outliers, right? So basically what we determine is like if we have, we have an idea historically from this particular health facility for this data element, we have a regular, a range of data that may be plausible, that may look like possible. Okay. But in case, if there are some data which are abnormally high or abnormally low, this we call as outlier. Whenever we notice outlier, and if we have a way of determining whether there are any outliers present, that is an indicator that these data that is there are not internally consistent, right? So that is one measure. The second one is, of course, year-to-year consistency, right? Year-to-year consistency may mean, so say for example, you may notice that there are some data elements which are seasonal, right? So basically, like you may notice that the value submitted may be very high in some of the months and very low in few of the months. So if that's the case, if you are just looking at just 1 year, you will see a zigzag pattern, right? So we may not really be able to understand just by looking at data from 1 year. Okay, now in some of the months it's high, some of the months it's low. Is it just because is it a data quality issue, or this is just a norm? Right? You may not be able to get that idea. So for you to get that idea, what you can do is you can just see the submissions from previous years for the same months, right? So if you are seeing the same pattern following every year on the same during the same months, then you can just say, okay, this is the norm. This is not something very unusual. So that's why we are checking the consistency from year to year. And also, the third one is we have something called consistency of related indicators. So related indicators mean usually there is some kind of relationship between two indicators. So for example, we can say DPT1 and DPT3 or ANC1 and ANC3. So I suppose that you all are aware about ANC antenatal. These are regular health terms I'll be using frequently here. So basically, now if we have set number for the DPT1 visit, right? The DPT3 visits are somewhat related. So if like 100 people come for DPT1, okay, I'm just asking a question. So let's take the ANC, right? So for the ANC, it's one visit. We have 100 people that we are seeing, okay? Right? So if we are following the same cohort, what would be the number for the ANC3? Should it be higher than 100, or can be equal than 100, or equal or less than 100? What do you think? In usual context in our health systems. Is my question clear? So I'm comparing the number of visits for antenatal clinic 1 and 3. So if the number of visits that we are seeing for antenatal clinic 1, right, what would be the number that we are expecting to, ANC 1, if the number is 100, what would be the number that we are hoping to see for ANC 3? Should it be higher than ANC 1 or equal to ANC 1, or equal or less than ANC 1? ANC 1.
Equal or less than ANC 1.
Equal or less than ANC 1. Why is that usually? That is
because those people, those cohorts are expected to come. Additional cohorts will not be expected.
Exactly. So it can't be higher, but usually there is some level of dropouts that we are practically seeing. So because of that, the numbers are usually
in Sri Lanka. I think there's we can't say exactly, because some areas are there close to schools and other places where third visits are higher compared to the first visit. But in a rural area, first visit is higher compared to third visit. There is some discrepancy on that line.
Yeah, I was talking generally, and that's why I was mentioning if you are following the same cohort, right? So that of course, so all these what I'm mentioning are subjective, and that's why you are not just depending on one factor. So you put them all together with the contextual understanding of that particular area. So that's why I always mentioned we should not really depend on one factor, but if we have multiple factors that are there for us to get this idea, then we may be able to understand the subtle differences that you are mentioning. For example, Deepal, the thing is like, so like if we know historically this is the pattern of this particular province or this particular MOH area, medical officer of health area, then we may be able to get an idea this is a norm, something like that. Okay, right. And the other thing is the verification factor, right? Whether like if we have two clinic registers reporting the data and whether there is any, like, I mean, say for example, if we have some data from facility survey, right? We can compare the two data items and see whether there is some consistency between the data items that are produced from two different sources, right? As a verification factor. So these are the factors that we are using for to identify the internal consistency of data, right? So what you're seeing here is an extract, a screenshot from WHO Data Quality Review. So this we'll be doing next. So what I'm trying to highlight is, now here in this WHO Data Quality app, we are able to see some outliers, right? So there are some available tabs available which are defining different functionalities. So you can see the ones that are appearing in pink color here and here are kind of outliers which are not plausible with the data of the remaining months, right? You can see like it's mostly around 2000 and 1080s, 90s, but here you are seeing 4000s and here you are seeing 8000s, whereas the average is around 3000s and 4000s, right? So this particular application, the WHO data quality application, it has this functionality where you can quickly analyze the outliers and you are able to visualize it. How to do that? We will show you. Okay. But what do you think about this value that you are seeing, the 3600 value in June 2018? Is that an outlier or not? Because all others are around 4000. What do you think about that one? Why is that one not highlighted?
It is within the normal ranges, 2-3 standard deviations.
Yeah, okay, good that you highlighted that. So in this WHO data quality application, we can set the levels that we are feeling as abnormal, right? So, I mean, it's up to us. So if we just define like, okay, we want to see minus 2 SD or more, minus 3 SD or more, like, I mean, the range we can define. So based on the range, maybe some values which are kind of an outlier may not really be an extreme outlier for us to be highlighted in this application. So I was just highlighting. Varun will explain it further when he is demonstrating. Okay. What do we see here? Okay, we are seeing two diagrams. The first one here is a line diagram, also an extract from WHO data quality tool. It's a line diagram, and in this one we have 3 lines. So if you just look at the legend, you will be able to understand one line. This orange one is from 2015 to 16 data, then light blue is from 16 to 17. This one is from 17 to 18. So basically what we are doing is we are actually looking at this rotavirus 2 doses administered, the number of doses on each of the month in these 3 years. Of course, in latest version of DHIS2, this year-on-year chart type is available and you can do that. But now this about 2 years back, WHO data quality tool is the only one which was able to do that. So this is what we mean by you can see year over year, month to month, year to year type of analysis. So let us also focus on the diagram on your right. Of course, this again we will be discussing detail when we are doing the WHO DQ app. But basically what you are looking here is, right, you are looking at data for the month of November 2018, right, which relates to the same data that is that has been reported during the previous 2 years. Okay, you try to plot the data that is coming from each that in here represent. Just give me 1 second for me to attend to something. Right. So, right. let me come back. Sorry about that. Yeah. So basically, what you're seeing here, in each of this dot is a data item which is being reported by each of the health facilities, right? So what it looks as is the data that is reported from November 2018, and it compares with the data that has been reported over the years during last 2 years, right? And it plots the individual data value, and the x-axis, of course, the average over 11 previous periods. So here, of course, it is not 2 years, it's the 11 previous periods. If it is monthly, of course, last 11 months, and it compares with the data that is reported in the November, that is this month, right? And then this, the line that you are seeing, the dark black line, is the average value that should actually have appear if the values are kind of ideally consistent with the average that is coming from last 11 periods. And these two, the light black lines, are the minus and plus 33% levels, right? So what it is looking at is, if for some reason one of the facilities are out of these two, I mean this range, plus and minus 33%, then of course it will be highlighted here. So for example, just by looking at it, I'm seeing this one, and of course this one, which are reporting abnormal numbers. Can you see? Right. How to do that and what else to know about these things, we will do in a while. This is also another extract from the WHO DQ app, which is showing the inconsistency of related indicators. So for example, I was mentioning to you about antenatal clinic 1 visits to antenatal clinic 3, ANC1 to ANC3. And also here what we are looking at is DPT1 to DPT3 dropout rate, right? So here we have positive. I mean, like, so usually what happens is, because usually if the values are the value of DPT3 is less, equal or less than DPT1, the dropout rate should be positive, right? But in case if you for some reason see a negative value, which means that DPT3 is higher than the DPT1, then you have to always check whether there has been any data quality issues, right? So what we can do in this using the WHO DQ app is, we can just look at the areas or the districts that are highlighted, and we can drill down further to understand whether there has been any data quality issues. Okay, so this type of analysis, which you can do just by sitting in front of your computer, will really help you to understand where the issues are, and you can just communicate the users without wasting your time travel. Okay, and then the other thing is, if you find some extreme outliers, right? And we have this, what we did yesterday is, we have validation rules. Okay, if you run the validation rule analysis, then it should be able to highlight if there are any data items which are not meeting the normal validation rule criteria, right? So these also we can use when we are using the data quality tools which are available in DHIS2 to perform a data quality analysis. Okay. Right, so the other factor, of course, is the data verification surveys that we have, right, which checks the consistency between the data that is reported in the registers and the in different registers and the other reported data. So this, of course, we for us to do it, we need to have some access to the other surveys which are there in the country, right? And then we can check and compare whether there is any differences between the related data from different sources, right? But of course, this is sometimes a bit difficult because you need to have some access to get these different data sources. Okay. Fine. And then we will just look at the third one, which is of course the external consistency. So that means whether our routine HMIS data or the routine data that is reported to our information system is tallying with other surveys, right, that are also collecting data. So for example, we may have the routine data that is coming, and also we may have the demographic and health survey, the DHS, which is also collecting some data. But of course, the periodicity is different, right? The surveys you will do, it may have some sampling available, and you may not do frequent. You may do it once in every 5 years, 10 years. But then again, you can check whether there are these related indicators, data items, which are coming from routine sources and the surveys, and see whether there is any discrepancy. So this is what we mean by external consistency. So here, of course, again, we have two sources of data measuring the same health indicator, right? And the sources of data could be HMIS compared to the household surveys, or else doses administers compared to the doses supplied. So for example, we may have doses administered that are routinely reported to our information system, but doses supplied may be coming from a different stock management system, and we can see whether there is any discrepancy between the administered compared to supplied, unless of course doses don't evaporate, right? I mean, that doesn't usually happen. So you can see, like, if there is some discrepancy, of course that is something for you to be concerned about and check. Okay. All right, so what you're seeing here is something very important. So basically, we are doing an external comparison, right? Comparison of survey data. So for example, what you are seeing here is basically the ANC1, antenatal 1 coverage, okay? So here you are seeing the ones that you are seeing in the blue are from the routine data, that is of HMIS. And the ones that you are seeing in red are the data coming from a survey. So what do you notice here? What do you notice here? Is there a discrepancy? If so, what is the discrepancy between the routine data and survey data? What's the discrepancy? Anyone? Which is very obvious.
Survey findings are higher value compared to routine values. It's about plus or minus 50% difference.
Yeah. So what do you think would be the reason for this? In a general context, in a global context, what would be the reason for this difference?
Survey for
Maybe the sample that the survey was done. Maybe it might have focused on the urban settings where access to health service is higher than the rural setting.
Okay, right. But here, one thing to know is ANC1 coverage, okay, not number of ANC1. And what, Deepal, were you mentioning something different, or it's the same?
Yeah, another thing is that regarding survey sampling is one thing. Second thing is a number of protein coverage is smaller. That's mean it's not covered all population that routine services.
Right. So there was something that I can actually connect to the correct answer that I want to highlight. So basically, this happens in a global context is because now, if you can look at this, it's a ANC1 coverage. So how is this kind of formulated? This is a data element or indicator?
It's an indicator.
This
So
is
the
an indicator.
so the denominator will be different in both contexts.
Not that it is different. Different as in, like, you are saying, like, two different
value.
concepts
The values.
of data. So yeah, exactly.
No.
Yeah, that's
Same
the correct
with a
answer.
different
Yes.
value.
Yes, exactly. That's the answer. So in general context, this happens mainly because of the denominator, right? So the population statistics that you are taking would be different. So for example, this survey data is coming from, like, survey data, maybe using a particular denominator, which is very much different to the denominator, the population data that our is having. So if that is different, sorry?
That's all. No, here, entro.
I think I can proceed. Yeah. So this is because of the denominator, right? So for example, now let me just see whether we have, yeah. Okay. So here you can see, for example, now this is in fact like the ratio of population projection from Bureau of Statistics to a UN projection, right? So basically, like, there are two entities that are reporting the population. One is the Bureau of Statistics, that may be a country statistics, as opposed to the UN projection, which is of course coming from the United Nations. So basically, what it says is there is now, for this particular data set, the ratio is 1.119. So around 12% So basically the statistics that is coming from the bureau is 12% higher than the statistics that is reported from the UN. So 12% higher definitely is going to impact the coverage statistics. So that is why you were seeing that discrepancy, right? So always when you are talking about coverage statistics, just check whether if there is a discrepancy, always look at the denominator data, because this denominator data is the one that is responsible for these kind of discrepancies. Right, so the thing is basically now when you are using sometimes when you are using the data quality tool, right, you may not be able to, one disadvantage that you are having is you are not able to embed these the visualizations that you get in the DHIS2 dashboard, because the tool itself has a dashboard, but you can't embed it in DHIS2. So the solution is try as much as possible, if these are possible in our analytic tools like pivot table or data visuals, try to develop this statistics, the visualizations using this application, so that you can embed them in the DHIS2 dashboards, right? Okay. So with this, I think we can conclude this presentation on data quality review. So basically what I discussed in this data quality review is, I started off, let me summarize because I have been doing this for like 1 hour. Let me summarize what I have done in this for last 1 hour. So I started off mentioning that now we just cannot ask people to enter data. That may be the first step, right? We will just implement information system and we ask people to enter data. Okay, keep on entering data. But then people will just be entering data. But for us to actually use this data for a meaningful decision making, we have to really rely upon data, right? For us to happen, because of course we are not God, is to make sure that the data that is entered at the facility level is of high quality. So to achieve this, there are some various mechanisms that have been traditionally implemented by countries. Okay, so these measures include usually facility surveys. So how I mentioned how these facility surveys are conducted, and I mentioned the negatives of it, like time consuming. It will be on a different sample, right? Not covering the entire population, likewise. But the other solution which is available for us by using tools such as DHIS2 is the option of data desk review. The data quality desk review is such an amazing feature, that this amazing procedure that we can implement, where we don't really need to travel, and we can drill up to the grassroots level. Right? We can just sit at national level and just go digging, so that people are taking actions, right? Which is possible using DHIS2. So to structure this entire data quality review, then I also mentioned that the frequency that you should be doing it. So at facility and district level, you may be doing it monthly. At national level, you have to do it at least a data quality review annually preceding the data review that happens at national level. And then for strategic planning, we can have some period, the data quality reviews conducted in a longer periodicity, like 3 to 5 years. Then I mentioned to structure this process, we have to adapt a data quality review framework, right? So generally we are using the WHO recommended data quality review framework, which has 4 steps. Then I was going through each of the steps that I included in this framework, which includes completeness, timeliness, and then the plausibility or consistency between internal sources, then the consistency between external sources, and of course, finally, the effect it has by the denominator. So these are the 4 steps that are included in the data quality review, right? So our next step would be to highlight the WHO data quality tool, which is going into depths of all these factors that I have highlighted up to now. Okay. Any questions? If there's any, or else we can take a short break of Priyanka. How many minutes? Like 5 minutes would be fine.